Welcome, everybody. This is a special seminar for IRP because we have a visitor. We have Dr. Wendell Primus visiting us from D.C. He, as you all know, is a senior pilot. Oh, I'm Donna Friedson, by the way. I lead health policy programs at the Institute for Research on Poverty. Dr. Primus is the senior policy analyst for the Speaker of the House, Nancy Pelosi. He goes without introduction, but I will give you a few of the points of his very impressive career resume. He serves as a senior policy advisor on budget and health issues in the House for Speaker Pelosi. He was a lead staffer on developing and getting the Affordable Care Act passed, and now, of course, what he's here to talk about today with prescription drug pricing reform. He's previously served as the minority staff director at the Joint Economic Committee, served in the Clinton administration in Health and Human Services, chief economist in the House Ways and Means Committee, staff director in the committee's subcommittee on human resources, and it goes on and on. Dr. Primus received a PhD in economics from Iowa State University. We're so lucky to have him here today in the midst of so much going on in the arena of what he's speaking about, so thank you very much. Come on up.
Well, good afternoon, all. It's a pleasure to be here. I was on this campus many times about 50 years ago, and I actually worked at the Institute for Research on Poverty. One of the reasons, and I may get booed for this, but one of the reasons I'm here is because I got an invite to go to the Iowa-Wisconsin game, where one of my cousins is actually the starting quarterback for Iowa. So I have mixed emotions about this game. But it is a pleasure to be here. And I'm going to talk to you about, and thanks for that kind introduction. This is, I think, one of the most important things I've worked on because it's a very small team relative to the team that we had when we had the Obama administration and the Senate and the House working on the Affordable Care Act. Right now, we are only in charge, as you know, of only one of those three places, i.e. the House. So I want to begin. I've been lobbied many times in my nearly 15 years with a speaker on by bio firms, by big pharma, et cetera. They are not my favorite industry, but nevertheless, I think we're going to have an avalanche of new drugs coming out over the next few years. And these are going to be, provide us with some amazing cures. I mean, as I understand it, there's SMA drug is a spinal muscular atrophy. It affects about 400 babies in this country each year, and they're gone by age 2. And now we have a dose, I don't know the medical details, but basically Zolgensma, I think is how you pronounce it. It's going to sell for $2.1 million, but it's going to give those 400 babies, probably 200 of them on the Medicaid program roughly, a normal life expectancy. At least that's what I am told. And you know, we're seeing. I meet with some oncologists who are very excited. I mean, they think they have some great new tools in the toolbox, the CAR T and other gene and cell therapies. So the point is, I think this country is going to be confronted with some very important decisions about how we price prescription drugs and what it means for our society. I don't think I've still mastered the complexity of the supply chains, the wholesalers, the PBMs, the pharmacies, et cetera. And the other thing that I want to impress upon you is kind of the economics of drug development. I mean, that first drug literally cost $1 billion or more. So that's the investment that needs to be made. And then the next pill can probably be made for $1 or $2. I mean, it's, you know, so you have this huge fixed investment up front, and then you have each additional pill is really very inexpensive. And that's what gives pharma the ability to provide a lot of drugs at a very low cost. It's still that they're making money on those pills. It's just the economics of this all. And the other thing that I think is very unique here, relative to other technology companies, they do build on the investments that are made in the NIH, but so do other industries, et cetera. But what's unique is that the cost of that medicine, for the most part, patients also pay premiums and cost sharing, I'm well aware, but a lot of it's paid for by a third party. So when you all get your first driverless car, it's probably going to come out of your back pocket. It's not going to come out of a third party paying part of the cost. And I think that allows pharma and other companies to charge fairly high prices because they know it's going to be spread through the mechanism of a third-party payer, et cetera. So the need for lower drug prices, about 1 in 3 Americans report that they're not taking a medication due to cost. Between 2008 and 2015, the prices for the most commonly used brand name drugs increased 164%. I think this leads to kind of unsustainable spending, and then we have the growth in specialty drugs. The other thing, we are paying significantly more than other countries. There was a study, and it's on the Ways and Means website. We pay on average, and there's about 79 drugs in this particular study, about 4 times that of other countries. If you just take the issue of insulin, more than 100 million of us are diabetic or pre-diabetic. Diabetes is our highest spending category, and the U.S. insulin costs doubled, practically doubled, not quite, between 2012 and 2016. So there is the spending on the over-the-counter drugs. It doesn't include the drugs that are administered in doctors' hospitals and doctors' offices and hospitals. But you can see, that is a very steep spending curve between about 1995 and 2015. And there are some of our best-selling drugs, Lipitor, from this 25-year period, a little more than that, I guess. $95 billion, Humira, $76 billion, et cetera. So that is what given rise to the need to do something about drug pricing, and the voters are overwhelmingly with this. The polling here is just unbelievable. So I've been in discussions with the administration for some time, not negotiations as the papers would have you believe. And the simple point I've been making to the administration is they do not have the authority or the clout or the power to negotiate on drugs. There's explicit prohibition in the Medicare Part D program, and they don't have the tools. So they've tried to do something on the rebate rule, and they put it out. The Office of the Actuary said it would actually increase drug spending. The Congressional Budget Office echoed that soon later. And I was telling the administration, it doesn't work. You're going to spend more on drug companies. You're not lowering prices. And then they have a Part B demo. Whatever authority they do have is there because of the Affordable Care Act. And I don't think, again, they may have the authority to do something in the CMMI, the Center on, the CMMI program, to do some quote-unquote research. But again, that entity that they're trying to set up in these regs, I don't think works. So we haven't seen the final rule, but my argument is nothing they do, really, they don't have the power. So we, the leadership team, and I worked with Ways and Means, Energy and Commerce committee staff, and Education and Labor. We've been working for about a year. And we put together basically 3 titles: drug negotiation, which I'm going to tell you about, inflationary caps, Part D restructuring, and then we're going to use the savings to make major improvements in the Medicare program. So basically, in the past, the Congressional Budget Office did not give any savings for removing the Part D non-interference clause. I mean, if you just said the Secretary may negotiate, CBO was not going to give any savings for that legislative language. And the reason basically was that it is the tool. So the short line, my one sentence summary of Title I is, this title gives the Secretary the authority, the mandate, and the tools to effectively negotiate the price of prescription drugs. And I also want to stress that this is not price setting. This is true negotiation. Right now, the Secretary does not have the information to determine what the price ought to be. For example, going back to that SMA drug, how is she to determine whether the price is 2.1 million or something lower? And it's unlike what we did when we set hospital DRGs in the early 1980s, when we did physician price setting in the late 80s, early 90s, and also again in the late 90s. Again, my point here is the Secretary does not have the tools. So what we say basically, the four tools are, so it's closer here, is that the drug companies on a confidential basis have to give over to the Secretary the cost of R&D, including the blind alleys they went down, sales, a lot of information upon which then the Secretary can start to think about what that means for pricing. There's also transparency where, again, each year the Secretary must select from a list of 125 Part D drugs, over-the-counter drugs, and 125 other drugs, pediatric drugs, drugs that are administered in hospitals and doctors' offices. And all of these drugs must be non-competitive. In other words, there's not a generic or biosimilar drug. So these drugs are truly without competition, and it's the drugs where we spend the most money. The Americans spend the most money. That's the criteria. So orphan drugs, drugs like that, are not in that list. So if the Secretary picks those drugs, and then comes back to the American public or Congress and says we got nothing, no Republican Secretary, no Democratic Secretary is going to want to say, I achieved nada. Then these last two tools probably do most of the work. One is a non-compliance fee that starts at 65% and escalates to 95%. Now, that excise tax is never supposed to be assessed. That is the tool that brings the drug companies to the table, that gets them to supply the needed information, etc. And why does it have to be so frickin' high? Well, the answer to that is, if you're trying to lower a drug from 4 times on average, and some drugs are 5 or 6 times, we want to actually lower the price. We don't want money just flowing into the U.S. Treasury. So if you want to get the drug company to negotiate on a drug that is 5 times more expensive here than in Western Europe, you've got to have a pretty high excise tax, or they'll just say, we'll pay the excise tax and not lower prices. And that is not the outcome we wanted to achieve. So that is the thing that CBO in their 29-page report said is the thing that gives the CBO the ability to say this bill saves a lot of money, or this title even saves a lot of money. And then we said we did not want the price to be higher than 1.2 times the weighted prices in Japan, Australia, Germany, France, United Kingdom, and Canada. So those were the 6 countries we compared it to, and we said the price at the end of the day has to be less than 1.2 times that average. Now, I actually think some prices can be driven substantially below that. I'm an economist by training, and therefore, at some point after drug companies have recovered their R&D many times, which they have on some of those high-selling drugs that I showed you, the price ought to be driven much closer to marginal cost. And none of these countries are anywhere near the marginal cost of producing the drug. So, in my mind, the Secretary should be able to achieve, in some instances, something substantially below that on new launch drugs, on drugs that are truly innovative. The Secretary has some range then to reward that company that produced that drug considerably more. Or probably the truth is the bio company that they bought the rights to, and then it's Big Pharma that actually does the manufacturing. So the other thing is, we worried. The members, the chairman, the speaker said, if we only lowered drug prices in Medicare and Medicaid, we were worried that pharma would then raise prices on commercial insurers because they do not have the clout. So we said commercial insurers, employer plans, et cetera, could take advantage of the price that comes out of the secretarial negotiation. And I'll come back to this, and the secretary is directed to take into account research and development cost, and we basically say the secretary in these negotiations should achieve the lowest maximum fair price for each selected drug while appropriately rewarding innovation. Now that gives a lot of leeway to the secretary, but as you'll see, that's my primary argument for why we're not hurting innovation, which is what we're getting hit on. On new launch drugs, if they're in that list of 125 times 2 and are above kind of the current family median income, they are immediately selected for negotiation. So these are some of the examples of negotiation eligible drugs. And some of these drugs we are spending a lot of money just in the Medicare program, let alone across all payers. Then in Titles 2 and 3, similar to the Senate Finance Bill, we basically say that prices can't rise faster than inflation. We use a 2016 base year. And then we also restructure Part D. Right now there is no limit on on beneficiary cost. We take that out-of-pocket limit down to $2,000. The Senate Finance Committee has a $3,100 limit. And I want to say something interesting here about Chairman Grassley. He's from Iowa. He reported out a bill out of his committee where 9 of his 15 Republicans left him. Now, that is not something we normally do in Washington. I tell the committee staff, think about your chairman reporting out a bill with completely Republican support and a minority of Democratic support. That's not the way we normally do things. And I think it's a credit to Mr. Grassley, who probably doesn't have much pharma companies in Iowa, but letting that aside, I think he does believe that Iowans are paying way too much for prescription drug prices. And he is talking about passing a bill on the Senate floor with about 15 to 20 Republicans and maybe 45 out of 46 Democrats. And again, that is not the way you normally do things in Washington. So I take my hats off to Mr. Grassley. So there's our Part D resign. 2020 there is current law, the bar graph. And so, the first little bit starting from the bottom, the initial deductible is all paid by beneficiaries. Then it's split. And that also will have implications for prices, et cetera. Then the other thing about this bill, which is why it's still not on the floor and why it's not going to be on the floor until December, is at the end of the day here, this bill is going to save about $500 billion plus. Right now we have a score from CBO that says in part, just the Title I, the negotiation part, it saves $345 billion in the Part D program. But that doesn't include the savings, and there will be budget implications of what happens on the commercial or to business, et cetera. There's Medicaid savings, et cetera. So when it's all said and done, we're going to get a score of $500 billion or more. And then we're going to plow those savings back into making the Medicare a much better program by improving the low-income subsidy, by including the Medicare savings programs, which helps low-income Americans pay for the premiums and the cost sharing. We're going to also probably provide dental, vision, and hearing benefits in the Medicare program. We're going to invest some money into NIH and FDA to approve drugs faster. It gives us a talking point that we're not hurting innovation. We're going to do some other things as well. But so my simple thing that to Mr. Grogan at the White House, you're going to force your Republicans not only not wanting to lower prescription drug prices, you're also going to say you don't want to improve the Medicare program. And I think that has a lot of implications for seniors and et cetera. So there's been some polling on this. I think this polling is out of sight. This was done by Jeff Guerin. So if you just said Democrats in Congress have proposed legislation to give Medicare the power to negotiate, to lower prices, you get a 71 favorable, 7 against. And then we'll also apply the lower prices to all patients, not just those covered by Medicare. It goes up 77 to 8. And then if you also talk about how you would use the savings to improve Medicare, we get 77 to 5. The point is, all the aspects of this bill are fairly popular, and I think right now there's no, the conventional wisdom in D.C. is we're not going to get any Republican support. I think when they fully understand what we're doing here, when we get the CBO estimate, et cetera, and they're confronted with compelling results like this, that we may get some Republicans. And I also think when the I word, the impeachment stuff, is completely behind us, whatever it turns out to be, that will also change the administration's opinion of some of this. So what did the CBO and the Office of the Actuary actually say? I want to stress the word that it was preliminary. So again, just Title I, we got $345 billion of savings. The other thing they said, and they said a bunch of things, that because lower prices will increase the use of drugs and improve people's health, we actually give the bill a $42 billion savings in parts A and B, the hospital part and the physician part, because we're lowering healthcare cost in those two titles. So more medication adherence, lower prices, medication adherence actually saves us money in part A and B. And they anticipate that pharma revenues, again, it's a wide estimate there, is a 0.5 to $1 trillion from just negotiating on about 175 drugs over the 7-year period. So again, and I'll come back to this, yours truly has taken a lot of hits from the uber progressive side that says, why aren't we negotiating on more drugs? Well, the answer is, I don't think we can. Great Britain negotiated on about 17 drugs per year in the first 10 years when they undertook negotiation. There's just going to be a huge learning curve. Personally, I believe the 25 number is probably too high. Now, I think one can start out with a smaller number and quickly negotiate on more drugs, but to figure out, one, whether the drug company is telling you the truth when they give us all the information, even the simple task of comparing a drug here to a drug in West Germany to get the right dosage to make sure, and to get, what is the price that actually flows to the drug company after rebates, etc. That in itself is not necessarily an easy task. So I think there's going to be clearly a learning curve at CMS or in the office of the secretary. And I also think politically, I want this to be called negotiation, not price setting. But that's a huge hit in revenues. I mean, the Office of the Actuary predicts somewhat lower savings to the federal government, $39 billion in savings to state governments, $46 billion to private businesses, and families, households, will also get a reduction in cost of $160 billion, split roughly evenly between lower premiums and lower cost sharing. So here is some of the advertising. It runs every day in the Hill Rags. Maybe some of you have seen it in the New York Times. It is amazing how much money is being spent by pharma. They do not like this bill. And there's another one I got NAM, the National Association of Manufacturers, the Chamber, Pharma, the California Life Sciences, et cetera, spending lots of money. And then the main argument that's coming against the bill is that the bill is going to, innovation is going to disappear. I think that is way overstating it. While those estimated savings, and if you use the point estimate of, let's say, $1 trillion, that represents about 3 to 6% of revenue to pharmaceutical companies globally. So I'm not saying that's insignificant, but it's not like they're taking a 30% haircut. We will invest some monies at NIH. I also think the bill will have the impact of raising prices in Western Europe a bit. I do think this bill that foreign consumers are going to pay a little more of the innovation cost. I quote there in the fifth bullet Avik Roy, who is a prominent conservative health economist. He basically argues, and I think there's language in the bill that will support this, that it may mean that fewer Me Too drugs are developed, not the truly innovative drugs. And I think there's plenty of other ways. The last bullet for pharma, they could hire a few less lobbyists. I mean, they have a roughly 1.5 for every member and senator in Congress. The amount of money, you can't watch a sports game on weekends on TV without seeing lots of TV advertising for pharmaceutical companies, et cetera. Large companies sometimes spend 10 percentage points more on advertising than they do on R&D. I would also argue, and I've made this argument to the White House many times, that this bill completely matches Trump's promises. He talked a lot about lowering drug prices. He talked about making sure Americans didn't pay more than Western Europe. These are some of his quotes. And I think at the end of the day, he does really want to lower drug prices. And I thought, and I still think at the end of the day, we are going to get administration support despite some recent comments they have made. In conclusion, this bill has been one of the more difficult ones, again, because we're working very small team here. One of the difficulties CBO has had is the multiple interactions here of what this bill does. I mean, I talked a little bit about more medication adherence having an impact on Part A and B. It's also true that when we improve the Medicare program by improvements in the LIS, that has an impact back on how many drugs are consumed, et cetera. So they pulled their hair out, is what they would say a couple times when we've talked about getting this bill scored adequately. Then there is something called the 340B program. How many of you know something about the 340B program? Well, that's a program that is part of current law that is dealing with the fact that we have these high drug prices. So it allows certain providers to get a very big discount and then to sell that drug to commercial insurers at a higher rate. Well, we're not taking away the fact that they might get a lower discount, but we are taking, because on these negotiated drugs, the commercial price will have fallen a lot. And so the HIV community, others are saying, what are you doing about that? And it's very hard, and I've asked HRSA and the Office of the Actuary to tell me what is the impact of 340B. So it's very hard to take that program away in some sense and then try to replicate it. Now, I can help hospitals by some of these savings, by taking away some of the dish cuts. I can help providers a bit by et cetera, but it's very hard to replicate that program. And it's and then we're still, I mean, right now my sense of this is we have this bill centered correctly. The bill cannot move to the left, as some. I mean, we've had some uber grassroots organizations like Social Security Works, Public Citizen saying, why don't you negotiate on all drugs? Well, you can't negotiate on all drugs. Then it's clearly price setting. And, to the moderates who have to, we have to defend this innovation argument. I don't think we can move the bill to the right or the left. So as we go through the structure of the floor debate, that is something my boss is going to have to manage, and she will manage it well. I have no complete confidence. But it just, it's been very difficult in where I've got pharma on the one hand and the uber left on the other hand. And it is hard to defend the 25 number. I said the secretary should take 25. Well, to the average member, they say, why only 25? Surely the secretary can negotiate on more. The discussions with the administration have, for the moment, gone south. And then the interaction with extenders and surprise billing, I was telling the committee staff, let's get the drug pricing debate out of hand. Let's get that done first. Don't do surprise billing, because then you're going to have the providers at war with employers and insurance companies, but they didn't listen. And so we've had surprise billing where we do literally have a war going on between the insurance industry and the employers on one hand and the providers on another. I was trying to postpone that fight for later. Not that we got to do something about surprise billing. Then ensuring all Americans have access. There's one amendment here that I talked to Andrea Palm yesterday. I'm talking to some other people. I haven't gotten it across the finish line. But again, with this avalanche of new drugs, I think some of them, there's a huge proportion of the Medicaid, or a significant proportion of the Medicaid population that's going to use those drugs. I do not want to see happen what happened on Sovaldi, where states put varying barriers. And so I'm going back to that SMA drug. I want all babies in America to have access to the drug, even the ones born in Texas or Wisconsin, et cetera. And I think my understanding of current law is the Medicaid program is not supposed to put barriers in the way. But with these price tags, I think states will. I even understand in this state, you put some barriers between the use of Sovaldi and Harvoni, et cetera, the Hep C drug. So again, on some very expensive drugs that are going to affect the Medicaid population, I want the secretary in Washington, not 50 secretaries around the states negotiating with drug companies, and then maybe give a higher FMAP and basically tell the states, the outmates, not put any clinical barriers in the way of having your population get the benefit. That's not something that's currently part of the bill. I've got a little more work to do, but that is something I would like to get done. And I've talked to the speaker about it. She would like to get it done, but I just got to build some more support for it. And then we have all the pharma monies and that are going to hit our members, et cetera. So it's been an interesting journey. I think it's one that I take a lot of pride in. And with that, I'll open it up to Q&A. Thank you.
So, since medicine is very adept at always finding a new mechanism to make money, and so we have a bill in the legislature with 100 co-sponsors, and PBMs basically regulate what's going to be on your formulary. Do you see that the PBMs will be in charge of trying a way to circumvent 25 drugs or change formularies, and they're going to make their money, so what will be the impact if they can somehow circumvent and the consumer never feels the effects?
Well, no, I do think the consumer is going to feel the effect on the negotiation side and also on the inflation rebate. There's nothing I don't think that the PBMs can do to that, because most of the time, while in some cases there is therapeutic competition, there's no generic or biosimilar competition, and so we're taking a little bit of the ability for PBMs. I mean, whether they push consumers to Sovaldi or Harvoni or the insulin drugs, for example, where we have an authorized generic, but we don't have a true generic. But for the most part, the PBMs are still saying they're for this, even though I think it will hurt their revenues to some extent. And I don't think there's any way that they can undercut. But I do think, pharma is going to figure out a way to try to recoup. I mean, we've got the inflation rebates. We've got the commercial insurers that can take advantage of this. They can push some of the hit they're taking here in the U.S. to try to get Western Europe to do a little bit more. So we'll see what happens. They can, in my mind, they can spend a little less on advertising. So if this bill were to become law, all the impacts, I think are not completely known. But I think the American consumers will get a great part of this benefit. And again, directly, we're going to also improve the Medicare program. And again, I don't know. I mean, one of the things I still have not seen the final score. My 500 billion number is a bit of a guess on my part. I would like to think an educated guess, but it's not the final word. I'll go there and then there.
So I see this 25 number, and I'm wondering whether it'd be possible to establish a program whereby you have an incentive to particular companies to negotiate, and then say, okay, if you successfully negotiate in the first year one of their drugs, that then they don't have to be part of the negotiation for a certain number of years. Could you gain some cooperation? They're going to be strategic in terms of the way they respond anyhow, but is it possible to create an incentive system so that the large companies will be more forthcoming because they have something to gain in postponing the negotiation for other drugs?
I guess I haven't really thought about it. I've let that non-compliance fee do most of the work. And to me, it's kind of amazing when I saw the score from just negotiating this. I mean, it does tell you how concentrated our drug pricing is. I mean, again, very few drugs are where we spend a lot of the money. So I guess I haven't really thought through whether there's an incentive. I mean, right now, and the reason for also doing that Medicaid, that second to the last bullet there, is I think there's some small biofirms that they know they're developing drugs for the Medicaid population. I mean, other Americans too, but like sickle cell, and they're concerned that their product is going to get shunned, and so giving them a guarantee that they can sell to the Medicaid population is very important. And again, the language in the bill talks about making sure they get an adequate rate of return, and I think more than an adequate rate of return on a truly innovative drug. In my role, I have to talk to everybody, and I've made my case to the small biofirms, et cetera. So we'll see.
During the negotiation process, if the big farmers and the secretary disagree about the price, what stops the secretary from just saying either take the offer or pay? Do the firms have any leverage?
Well, yeah, they will. They're arguing they don't have a lot of leverage. I would say part of their leverage is, as they do now, they run to Congress and try to get us to do an end run around the administration. If they don't agree to a price ultimately, that non-compliance fee gets assessed. It means the money does roll into Treasury. It means the price does not go down. But my sense is that at the end of the day, and both CBO and the Office of the Actuary affirmed that they believe that that non-compliance fee would not be assessed, that the bill had enough clout that, again, a price would get established out of this process. And I do believe if the American public and pharma makes its case to Congress, it is tempering to some extent, I think, on the secretary's the real power here. We've given the secretary enormous power to negotiate on these drugs. I still think we can get this bill across the line, but I'll also confess I'm in the minority in more ways than one, and it'll be seen. But I think the House is going to pass this sometime in December, and then we'd like to go to negotiate with Mr. Grassley and Mr. Alexander, et cetera. And the real question is, and that's why I think putting this bill with the extenders, community health centers, doing something for hospitals, there's a lot of goodies, again, improving the Medicare program so that even Mr. McConnell can't say no when we're done with that House-Senate negotiation. That's the vision. We'll see.
What sort of standards, if any, are in place for the submission of information by these different companies in the negotiation process, so that when Merck submits its data for its product and Pfizer submits its data for its product, we know that the R&D costs are assessed in the same way, all these other issues that you talked about. And how do we know that an apple is an apple and so forth?
Well, it's a good question. And that's why I think the implementation of this, if it got enacted, is going to take some time. And that's why I think that number, probably the 25, and I have a huge problem selling that to members, that's why we can't, because those reports are going to have to be verified, and there's probably going to be inconsistencies between what we hear from different companies. So there's going to have to be some real expertise developed. But the bill primarily because I don't think the legislative branch of government can get into too much of those details. Otherwise, we'd never get the bill legislated. So it's a very valid question, and hopefully it will be left to some Democratic secretary to figure out. That's all I can say.
Does the bill address the importation of more or less expensive drugs from other companies such as Canada? If it does not, then what's the thinking coming from leadership on that?
I don't want to implicate all of the Democratic members, but I mean, our thinking, and I think the committee staff, is that's not a solution that's going to work ultimately. Yes, you can import a few drugs from Canada, but Big Pharma is not going to allow a lot of importation. So doing this kind of a bill, and you look at any cost estimate that you would get from CBO, it doesn't get anywhere close to the savings that we're getting from this bill. So I don't think that's a very effective solution. I think we need an American way of figuring out what the prices are on some of these very expensive drugs, and there is a balance we have to make between rewarding innovation and getting prices lowered. I'll go back there and then.
It's a little easier to see, and it looks like the estimates are based on savings to the Medicare program and sort of the reinvestment into Medicare. Can you talk a little bit more about how you see the impact of this spilling over into the private sector or other government programs like Medicaid?
Well, you saw the. I was supposed to get more information today, later this afternoon, from the Office of the Actuary. But so the Office of the Actuary did opine on all the, whereas CBO just opined thus far on the Medicare. Again, it was just Title I. It wasn't the other titles. So I think when CBO gets all done with its cost, this savings to private business is going to be there, et cetera, because private businesses, and we have been successful in getting the Pacific Business Group on health, and some business groups are coming out in favor of this because, again, that price, they can take advantage of it. I've yelled at the NAM lobbyist. I pulled her into my office and said, why are you doing this? I mean, I understand on your board you have a lot of pharmaceutical companies, but you also have a lot of companies that are going to get benefit from this. I think there is going to be a huge benefit, and then you have this impact on families, which CBO yet has not, opined on either. So I think they will have very good effects, but I don't really know the magnitude of them other than what the Office of the Actuary has said. And the Office of the Actuary only did Titles 1 and 2. The Actuary did not talk about the impact of Title 3, and and we haven't buttoned down how we're spending the program, and there's going to be meetings next week, because until we get scores on dental and hearing and vision and LIS, members can't make decisions about that because we don't even have the final score on the entire bill yet. I mean, I think it's going to be huge, but until we have all those scores in place from CBO and the Office of the Actuary, we can't finish the process. And that's why we've moved the goalpost. That's why we're not taking this bill up onto the floor until December.
So the one to prices in these other 6 countries. Because pharma then, for every new drug, has a change incentive policy, right? When they negotiate with, the one I know best is Australia, they have every incentive to try to push the price higher because it goes through and affects the price here. So you're worried that if you take prices today for the existing drugs, it can be an effective standard, but that in the future, it's less likely to be effective.
Yeah, but I didn't have a choice. And the reason I didn't have a choice is because I had long arguments with the Congressional Budget Office. And I was arguing that tools 1 to 3 initially gave the secretary enough clout. Why do we need the 1.2? There were people at CBO that didn't agree with me. But also, this is the max. I mean, so the secretary can go below that. And I've tried to point out many times to both CBO and the Office of the Actuary that it is a max. That I don't want their cost estimates to assume that everything comes in at 1.2. So this has been one of my ongoing arguments with the scores of the world. But yeah, I guess I think it will go up a little bit. I don't think it's going to go up dramatically in those countries. I mean, if you have information to believe that's a wrong assessment on my part, send me an email. So, I think there will be a little impact, but not much.
So wellness is wending its way through Congress and its ultimate fate that you're optimistic about. We have a lot of activity at the state level, both here and in states around the country. And various states have tried to do various things that have been not terribly successful, and you made your comments about drug importation. I guess what I'd be interested in is if you have any comment. We do have some people in this room who are currently involved in state policy making around this issue, and the governor is convening a task force to try to address this issue at the state level. What would you say to states right now about how they should be thinking about state level policy with regard to what they can expect to be happening at the federal level and how they should think about what they can do at the state level? Do you have any thoughts on that?
Well, I would say the number one thing is I would like support from states for doing what we're doing. That's number one. Number two, until we actually get this done, I think states need to do what they're doing. And I think Rebecca Gee has done some good things, and whatever you can do in this state to take away some of the barriers you put in terms of access to those drugs. But fundamentally, I do think it's the power of the federal government that needs to be invoked here, because I don't think it really makes sense to have different drug prices in different states, and I also don't think I want the Medicaid program to put in different barriers in different states. That's something I clearly think is not just. So again, all the more support, and I'd like to think we could get also some support from Republican governors that are having to grapple with this. So I need support. This is the bottom line. One last question, I guess.
Your first slide showed Zolgensma, the drug that's being advertised as a cure for SMA. How do the commercial and probably the government insurance markets aren't really built to handle things like gene therapy. Is there anything that could be done from a national standpoint to help handle these kind of drugs? I'm thinking from the perspective of like a small company that self-insures. If they have a patient who needs this, it basically bankrupts them, or a small health plan, or there are a lot of people who could have to pay for these drugs that don't have a sufficient risk base to diversify. What can the government do about that?
Well, let me just say a couple. One is I think this is a first step. I don't think it's the ultimate step by any means. I think there has to be, we put this in place. There might be some unintended consequences, but I think you raise a very important set of questions, which I was trying to get at. I mean, I do think this country is going to be confronted. I think we can deal with it. I'm not saying it's an impossible problem, but I think the CAR-T, these drugs are going to impose both miraculous things on the population, but also there is a price tag to be paid, and we're going to have to figure that out. So my answer at the moment is we need to determine what the correct price is, and we need to make sure that people don't have unwarranted or unjustified clinical barriers, and I think we're going to be confronting this, as your kind of question implied, for some time now. In terms of, I think reinsurance and other things and the Affordable Care Act was partly an answer to that. I mean, again, a small company could make the decision. I do have some risk. I'm an older. Let's say I employ more older people. I mean, I see nothing wrong with sending those people ultimately to the exchange. I mean, it's a bit of an accident why all of our health insurance is tied to employers. I mean, there's economic reasons for that, but I think there's also reasons why, if you're a very small employer, you don't say, I'll give you some increased wages and send those people into the exchange. So thank you.
Thank you.